Scapular fractures. This is my neighbor. He's 35 years old, and he had a motor car accident and developed this isolated injury, which is, by the way, very rare to be isolated. What do you think? How should I treat him? Should I conserve? Should I operate? I hope by the end of this lecture, I'll tell you how to recognize and evaluate scapular fractures, classify them, and identify the indications of surgery, as well as the operative approaches and the expected outcome. It's not common. It's less than 1% of all broken bones and about 3 to 5% of shoulder girdle fractures. And why is that? Because it's a really thin and elastic bone, which freely moves over the thoracic cage. So it's difficult to injure it. It is usually injured in high energy trauma, and that's why 90% of these patients have associated injuries. The mechanism is usually a direct blow, while indirect blows are uncommon, maybe fall on an outstretched hand with the head being pushed into the glenoid to cause a fracture of the glenoid or a fracture dislocation of the shoulder with a fractured glenoid. While most commonly it's a direct blow from high energy trauma, and this is associated with other fractures and other injuries in 70 to 100% of these patients. Most common injuries, fractures are ribs, clavicle, as well as skull, while most common injuries are head injuries, neurological injuries, as well as pneumothorax and pulmonary contusions, ruptures of the spleen, and the renal injuries. Clinical examination is very important to detect associated neurovascular status, injuries, and associated fractures and other injuries as well. X-rays, we usually need a true AT and a Y view. It's not common or easy to have an axillary view in these patients with scapular fractures. CT scans are standard with 3D reconstruction to evaluate these injuries. Traditionally, these fractures are minimally displaced and are treated non-operatively in about 90% of these scapular fractures. And this patient had an exarticular fracture of the body of the scapula, and this is 6 weeks post-injury. She has almost full range of motion. That's why 90% of these fractures are non or minimally displaced and show good results. However, since all 30 years since Nordqvist published a paper saying that out of 48 patients, he followed up 20 patients had malunions of the scapula, and 42% had residual symptoms in the manner of pain, functional deficits, decreased range of motion, and strength, as well as shoulder muscle imbalance. We know that malunited fractures of the scapula alters the shoulder girdle function, malalignment and arthrosis, dysfunction of the rotator cuff, impingement type of pain, as well as scapulothoracic dyskinesia. So, although traditionally we treat these patients non-operatively, more and more studies document the advantages of operative treatment, especially in patients who are indicated for surgery. And this is the main value of, I hope, this lecture, to point out which patients are indicated for surgery. The best classification out there and the most comprehensive is the AOTA classification, which was done by the AO Foundation and the American Orthopedic Trauma Association, and was published in the Journal Elbow Journal in 2013 by my dear friends Martin Yeager and Simon Lambert and quite a few other consultants as well. They divided the scapula into 4 components: the fossa, which is the articular fragment, the glenoid and its neck, the body, and the processes, which is the acromion and the coracoid. And they added the letter S to evaluate the lateral scapular suspension system. So if it involves the body, it's a B. If the fossa is involved, we talk about an F fracture. If both, it's an FB fracture. If the process of fractures, it's an FBP. or a BP, and we use S to designate the lateral scapular suspension system. There's two levels of classification, the basic one for rapid and simplified documentation, while there's an advanced system to put much more details into these injuries. Body fractures, B, are either extra-articular fractures with no glenoid involvement, or they involve the glenoid. If it's a B1, it's a simple fracture line that involves two or less breaks into the body, while more than two breaks is defined as a complex involvement. And we usually, I don't think you see my cursor there, and we usually use, look where it comes out, and this would be an SL B1 fracture, while this would be SML body fracture. What about the fossa fractures? The fossa fractures either are extra-articular, involve the neck, and they're FO, or an F1, which is a simple articular fracture, and F2 is a multifragmentary articular fracture. Process either P0 is a coracoid fracture, P2 is a acromion fracture, while P2 is a coracoid and acromion fracture, while the S0, there's no involvement of the lateral scapular suspension system, while S1 is an incomplete failure of that system, and S2 is a complete failure of the system. What is the indications of surgical treatment? In a landmark paper by my dear friend Peter Cole in 2012, he pointed out three major points. One that involves the body, which is angulation of the body. You can see in the middle picture there, or a glenopolar angle, which represents the rotation of the glenoid around the body, or the medial or lateral displacement of the glenoid. So let's see the importance of each of those. Which typically types of fractures need surgery? Those involving the glenoid fossa, or the articular fractures, those involving the neck fractures, and those involving ipsilateral fractures of the clavicle. You can see that these represent about 90% of the indications, 85% of the indications in the paper in the systematic review published by Landry in 2008. Intra-articular fractures that glenoid represent 10% of these fractures. They are usually minimally displaced and managed conservatively, but if they're displaced or associated with scapular injury, they are usually, with shoulder instability, they are usually fixed. The step of more than 2 millimeters is considered an indication of surgery. While glenoid neck fractures are most commonly as well managed conservatively, the indications of fixation include medialization of the glenoid or rotational angulation of the glenoid. How do you measure medialization? Through measuring the displacement of the lateral border. This medialization represents telescoping or shortening of the length or the width of the scapula, to be more accurate, and this is associated with muscular or rotator cuff dysfunction. If it's more than, if the medialization is more than 10 to 20 millimeters, then we probably will have dysfunction of the muscles around the shoulder, especially the rotator cuff, and this needs fixation. What about glenoid neck rotation or glenoid alignment? This is measured by the glenopolar angle, which is from the highest point of the most cranial point of the glenoid to the tip of the scapula and one parallel to the articular surface of the glenoid. This case is displaced and there's 18-degree angulation, and we know that there's a correlation of poor outcome with glenopolar angle less than 20 degrees, published in many articles. So restoration of the glenopolar angle is one of the goals of operative management of glenoid neck fractures. You can see it here, it's been restored from 18 to 32 degrees. What about extra-articular body angulation? More than 30 degrees is associated with scapular dyskinesia and is considered an indication of surgery. And definitely more than 45 degrees is an absolute indication of surgery. How do we operate on these patients surgically? We either go ventrally to do a deltopetal approach, which was very rarely used in coracoid fractures, anterior rim fractures, and acromion fractures, but most commonly we use a posterior approach, which gives us a very good access to the glenoid, the neck, and the body of the scapula. Classically, we use the Judet approach, which is a big L-shaped incision over the back of the scapula, but now more commonly we're using a Brodsky approach, which is a modification of Judet, in which we use a more vertical line of incision in one along the posterior aspect of the scapula parallel to the medial border. What about the Judet approach? It is the classical approach. It uses an internervous plane between the infraspinatus and the teres minor. The infraspinatus is elevated off the back of the scapula and being based on the on the suprascapular nerve there. We elevate it to expose the whole body, and we rotate the infraspinatus superiorly based on the suprascapular nerve, which is his nerve supply. Well, the Brodsky approach, again, a longitudinal incision over the lateral aspect of the shoulder, and we develop 3 internervous planes. We do not detach or elevate the infraspinatus off the back of the scapula. We use 3 windows to expose all the parts of the scapula, and the more you have experience, the more you get used to the Brodsky approach, the more you won't need the detachment or the elevation of the infraspinatus. Remember my dear neighbor? So what do you think? Is he indicated for surgery? Well, yes, he has got medialization more than 2 millimeters, and his glenopolar angle is less than 18 degrees. So he's indicated for surgery. We go into the operating room, we do Judet approach, we elevate, and we see the fracture and reduce it after elevating the infraspinatus and teres minor, the plane between those. Where do we put our plates? We could look at against the scapula, against the light, you find that the body is very thin, except at the glenoid area, the lateral border of the scapula, the spine of the scapula, and medial border of the scapula is where we usually can put our fixation. We go and we put 2 plates, one on the medial border and going up to the spine of the scapula, and on the lateral border, and restore the glenopolar angle and the medialization. 83% of patients going open reduction internal fixation of their scapula represent good to excellent results. And the postoperative complication most commonly is prominent or symptomatic hardware, some joint stiffness, residual pain or weakness, and sometimes infection. So my take-home message to you guys is beware of high incidence of associated injuries. You have to put this in mind when you see a fractured scapula. And conservative treatment is still the mainstay. However, operative treatment can yield excellent results and low complication rate when indicated in articular step-off, medial displacement more than 2 centimeters, glenopolar angle of less than 20 degrees, as well as a floating shoulder. These are considered to be operative indications. Stabilization with plate and screws through a posterior approach is the most commonly accepted open reduction internal fixation method. Thank you very much. I hope this was useful, and I hope I can catch up with questions if I'm able to log on to the internet in person when I arrive to Cairo. Thank you very much.